Good morning, good afternoon, and welcome everyone to today's webinar, Chaplains and Bereavement Support. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box in the platform's dashboard. You will have the opportunity to submit text questions for our presenters by typing your questions into the questions pane of that same control panel. You may send in your questions at any time during the presentation. We will collect those and hope to include them during a Q&A session at the end of today's presentation. With that, I'd like to introduce Paul Gauchut, convener of Transforming Chaplaincy's Hospice and Palliative Care Spiritual Care Network. He's a research chaplain with M Fairview Health. Paul?
Okay, thanks, Andy. And thanks everybody for joining us. If you're brand new to Transforming Chaplaincy, if this is your first webinar, we're especially glad that you are among us, whether you're a chaplain or whether you're one of our interprofessional partners. So glad that you are a part of this, or if you tune into this later on when this is on YouTube. Next slide, Andy, please. Yeah, so Andy mentioned this is who I am. In addition to the role I have as a research staff chaplain, I also am enrolled as a PhD student at the University of Maryland, currently in their palliative care program. And if you've never been through Research Literacy 101, we'd love to have you join us for our 17th cohort, and that begins in January of 2023. Next slide, Andy, please. So there are 9 official research networks that are part of Transforming Chaplaincy. We're glad that you are part of one of our webinars today. And this is one way in which we try to connect, inform, explore, and to coordinate with one another. And if you have a smartphone at the ready, and you're not yet a part of our network, which is free to join. Andy, next slide, please. We'd love to have you scan our QR code here and be a part of sliding into it. The people who are a part of this panel today know that I'm a baseball fan already, but it's especially kind of fun because the World Series begins on Friday. And again, if you're not a chaplain, next slide, please. We'd love to have you be a part of us. It's the same QR code. So chaplain, spiritual care providers, whatever title you prefer, this is not intended just to be only for us. There are thankfully over 900 of us that are part of this network already, but we would love to continue to grow, whether physician, social worker, nurse, PT, OT, and the whole realm of all of our preferred partners in the palliative care realm. Next slide, please. So it's my good fortune to introduce our presenter, our respondent, and our moderator for today's conversation. So I wish I could say Beba and I go way back, but we go back a little bit further. I think we met in Beba and I share the Christian tradition. So we met, oddly enough, on Ash Wednesday of all places at the University of Minnesota, where we both went to school to get our master's in public health. But as you can see, Beba's done a little bit more than that. So we're so glad that you are here, Beba, that you wised up a little bit and that you moved to a warmer climate, that you are now the manager for spiritual care with the Mayo system down in Jacksonville. Prior to your MPH, you're collecting master's degrees. I can see that you get your MDiv at the Jesuit School of Theology at Berkeley, another warm climate, or relatively warmer than Minnesota, and at VCU that you get your master's of patient counseling when you did your chaplain residency there, as well as the one that you completed in the Washington, D.C. area. And kudos, applause, congratulations on the grant that you received from the George Washington University through the John Templeton Foundation funding for a demonstration project based on the Generalist Specialist model of professional spiritual care to improve the quality of spiritual care in serious and chronic illness. And next slide, please. Another expert here. Oh, yeah, forgot. Thank you, Andy. In the spirit of baseball, I do like to ask people what their walk-up song would be were they a professional player. And Beba, you have enlightened me here. I had to look up who Sinak is, and it was fun to read about her work as a musician, and you selected I Know Who I Am. Next slide, please. So no stranger to Transforming Chaplaincy in any of these webinars is Sarah Byrne-Martelli. Sarah, I'm so glad that you are able to join us here and to part yourself from your work. Maybe this is a part of your work too, but as the inpatient palliative care chaplain at Massachusetts General Hospital Division of Palliative Care and Geriatric Medicine. Speaking of going way back, in 2002, when I was about 14 years old, you were starting your work as a palliative care hospice and bereavement coordinator back in the day. And since then, you know, you've continued to do these great things like be on the faculty, the Harvard Medical School Center for Palliative Care. Some of your educational history harkens back to your Doctor of Ministry at St. Vladimir's Orthodox Theological Seminary, your MDiv from Harvard Divinity School. And friends, you can look it up on Amazon and find Sarah's recently published book based on her DMin dissertation called Memory Internal: Living with Grief as Orthodox Christians. So thank you for being here, and thank you for that contribution to the literature. And I also have the privilege of, and the walk-up song. So Sarah, the previous one, she was with us, Aretha Franklin, again, rock steady. Yes, you are our version of Queen of Soul here. So thank you for that. Our last person to be a part of today's webinar today is James Adams. So James is currently serving as a staff chaplain with Houston Methodist System. And like some of our other people on today's webinar, has some experience as a palliative care chaplain, a bereavement coordinator, and a hospice chaplain. And James serves as our special interest group moderator for bereavement coordination within our larger hospice palliative spiritual care research network, and hopes that this SIG can be a sounding board for other bereavement coordinators or folks interested in it to integrate research into your professional practice. And I love this walk-up song. I would probably pick it myself, Crazy Train with Ozzy Osbourne. So thank you. Without further ado, Beba, the platform is yours. Take it away.
Thank you so much, Paul. Greetings and happy Spiritual Care Week to you all. I would just like to take this moment to say thank you to Transforming Chaplaincy for the amazing people who've made this happen. It is so hard to talk when your audience is not right in front of you, but I know that you are all there. So as you're listening today, I hope this presentation will open for you opportunities for conversation on this topic between you and your colleagues. Last year, I was invited to write a book chapter on bereavement support in a book entitled Integrating Palliative Care into Neurology. And bereavement support is going to be one of the chapters in the section dedicated to patients and caregivers support and end-of-life care. When I got this invitation, I quickly said yes, because I said to myself, I am a chaplain and the topic is bereavement support, so I can write that in my sleep. But no, I quickly realized that I could not do that as quickly as I thought. So it took for me several weeks of literature search and review, conversations with friends, and reflections on my own bereavement support practices and the bereavement support practices in my organization. So that is a little background. I am honored and grateful to have been invited to present today. And thanks to Paul and Andy for coordinating, and to Sarah who will be responding, and to James who will be doing the Q&A. Next slide, please. Today, I would just like us to just have an overview of the bereavement support pathway. That is, when is bereavement support provided, who provides it, and what is the format? How do we provide bereavement support in our different institutions? I also like us to look at the resources that we need to set up a bereavement support program, and as well as the benefits and the barriers to bereavement support. At the end, I also like us to look at some takeaways. You can put them in the chat. What are your takeaways from these? And some reflection questions for us as chaplains. Next slide. So I would like us to look at a few terms before we begin. You know, when I started this, I wanted to define all words: mourning, death, grieving, but I just said it's good to stay in scope. So I just chose these few terms that are really related to bereavement. Next slide. So as we all know, bereavement support is a condition of having recently lost a significant person through death. And if you've experienced grief before or you've seen it in others, it can be associated with a period of intense suffering for most individuals. And this moment of intense suffering can be influenced by the bereaved person's personal history, or maybe their personality, their previous losses in their lives. It could also be because of the relationship that they had with the deceased. Maybe the deceased person was their source of security or their source of support. And it could also be the circumstances around the death. Maybe it was unexpected, it was tragic, it was sudden. And it could also be the social context, religious or cultural. I remember the times when HIV and AIDS was rampant, how there was a lot of stigma, and when someone loses a loved one through that, there was a lot of shame and guilt. So the circumstances around the death could also influence that intensity and that suffering during the bereavement period. So adjustment to this can take months or even years, but it is subject to substantial variation between individuals and across cultures as well. Next slide. So let us move on to grief. Grief is that response, right? The response to the loss in all its totality. It's the thoughts and the feelings that come about when someone is experiencing loss in their life. And we know this as the fear, maybe the anger, the shame, the guilt. It could be resentment, sadness, and for some, it could be happiness or relief that the loved one is gone. And we know that grief is a process. It's not like a one-time event where someone can say, I am grieving now, tomorrow I'll be okay. Like the old model of grieving that used to say, let's let go and move on quickly to the next thing and move on quickly to the normal life, or moving on from distress to recovery. But this newer model of saying one can be grieving and at the same time still able to function. That's why I really like the dual process of grieving by Strobe and Schutz, because they said grieving could be a dynamic or oscillatory process where someone can be doing both things at the same time, yearning or reimagining life with their loved one, but also finding ways to cope with the consequences that occurred because of the loss. So yes, grieving is a process. Next slide. Now let's look at bereavement support. So bereavement support includes the care, the resources, and the services that we provide to caregivers and family members, leading up to and after the period the loved one dies. So bereavement support can vary widely, and we are going to see that later in this presentation. Some research that I read said bereavement support could differ if we are providing it in a regional area or if we are providing it in a metropolitan area. But I would also say the healthcare setting also matters, right? If it's a hospital, if it is a hospice setting where they have specific rules of how to, or standards of how to provide bereavement support, and then maybe if it is a long-term care facility, or maybe a religious or spiritual institution in the community, those will vary widely as well. Next slide. I'd like us to look at the bereavement experience. We know that some bereavement occurs within a relational or a familial, a social or spiritual context, but bereavement support, the experience is personal and it can be private, but it is unique to each person because everyone is different. People grieve in different ways. So understanding the effects of bereavement requires a close attention to the context. And I mentioned those contexts earlier. So what are the circumstances that are surrounding this death? The bereavement experience is going to be different for each person. So the effects also vary across time as well. So sometimes grief can come like in waves. The first month might be different, and then depending on the triggers that come along the way, it can also be different. So at whatever point we are offering bereavement support, we will see that it varies, it can vary. Because sometimes it's also difficult to know when to approach caregivers to start offering that support, or maybe to avoid it. What is that right time? Because there's little or no consistency, right, in terms of how people cope or how people are managing the stressors that come about after a person dies. So now the question for us is when is it time that people want to start talking about bereavement? When is that time when people start to say, do I initiate bereavement support? Do we initiate it for them? So we are going to see all that as we move along. Next slide, please. Let us look at the bereavement support pathway. And it's here that we're going to talk about the when, the who, and the how we provide bereavement support. Next slide. Now, when I was looking at when to provide bereavement support, I looked at a few studies to see what people are doing in other countries. Most of the ones that I saw were especially in Australia. So this the first study said the period of caregiving that immediately precedes the patient's death. And just to give a little background, this study was specifically for caregivers of persons with dementia. And we know how intense caring for dementia patients can be, right? Helping people with their activities of daily living, taking them to their appointments. So when caregivers know that their relatives are on that trajectory towards death, and when they are aware of their disabilities and their suffering and pain, they grieve their loss even before that person dies. And so I include this example for us to be mindful that context matters, and that the experience of each bereaved person also matters. So, and this is providing for us now a possibility that clinicians, chaplains, or whoever is providing the bereavement should understand that to view bereavement not only as a phenomenon that affects caregivers after the death, but also as one that affects caregivers before the death occurs. The next study was very rigorous, talked about different points during the grief trajectory, ranging from the time between admission and death, the time when death is imminent, at death, at 12 weeks, at 6 months after death, and at 12 months after death. And I'm sure in your institution, some of you might have experienced all this, or are in institutions that provide this kind of support to caregivers and to family members. The next study talked about at 1 month and at 6 months. And according to them, it is during this time frame that people are more open to counseling and group sessions. Next slide, please. Now, who provides bereavement support? I also looked at different studies, and this first one was done specifically within many palliative care services in Australia, and they noted that social workers, nurses, bereavement coordinators, and counselors, pastoral care workers were the main people who provide bereavement support, but that they were also noticing an increasing number of psychologists and medical doctors providing the support as well. The next study was one done in 2021, and they talked about healthcare professionals as a whole and trained personnel. They were big on the trained personnel piece because they said they have clinical experience, they have the ability to provide appropriate assurance and encouragement, and maybe constructive reflections or referrals when needed. The last study was done in 2020, and they talked about those who provide the bereavement support with palliative care clinicians, but they also mentioned this public health perspective where they talked about compassionate communities. And to them, this was local caring networks around the dying person and their families. So they thought accessing the community's capacity to provide bereavement support would maybe address multiple morbidities, maybe helping people with job loss, social isolation, and other mortalities such as suicide that is associated with bereavement. So I was very interested in that one because sometimes, as the other study said, we only look to trained personnel, but what about the support that we have around the communities as well? So who provides bereavement support in your institutions? Maybe sometimes the bereavement coordinator is a chaplain. In other institutions, the bereavement coordinator is not a chaplain. So it's just to be conscious who provides that support and what is your role as a chaplain in that process. Next slide, please. Now let's look at what to include in a bereavement support program. I tried to divide this into two. Maybe there is no need for us to look at it. Maybe the simple format and then the complex format. Maybe we can just roll it up in one, but I just separated it to say we can just provide these simple services to people, and it could be one or more contacts with the bereaved family, maybe through condolence cards, maybe calls or emails. It could also be bereavement support groups or activity-based programs, such as meditation. It could be music or art activities. Then it could also be counseling, and then remembrance activities, maybe sending cards during the anniversaries or during holidays, and then doing memorial services as well. And it could also be accessed through support sessions as individuals or as groups. Next slide, please. Then for a more complex program, we could do a risk assessment for prolonged grief. And we could do meaning reconstruction approaches to grief therapy, and it could be advocacy, maybe linking people to other trained facilities or trained facilitators as well. Let's go to the next slide. One thing that I left out in the previous group, we go back to the previous slide, please. So we see that one of the things there is providing information about psychological and emotional support. And the next one is providing information about legal or financial support as well. Sometimes the bureaucratic things that occur after a person dies, like, oh, I need to close their bank account, I need to have closure in one thing or another, I need to fill the paperwork, I need to find a funeral home. Sometimes when people are bereaved, they become confused. They are not able to do these things. And we can focus on the psychosocial, and we forget that this bureaucratic thing can also increase their psychosocial, their emotional distress as well. So we want to be able to take note of these things. I remember when I was doing my residency, one of the packages at VCU, one of the packages that we give to people after they were bereaved was we care for you, and it had all these kinds of resources to deal with the bureaucratic stuff inside. So that was very helpful. Next slide, please. Now let's look at some of the resources that we can use in our bereavement support process. I just want to draw your attention to the Chaplaincy Innovation Lab. They have a wealth of resources, especially this ebook on grief, like pages 18 to 21. They have so many resources. I just picked up these two books from there. So as chaplains, if you are not yet a part of the Chaplaincy Innovation Lab, please go there and see these resources. There is also one that I think as chaplains we know very well, the Barbara Kahn's series, especially the famous one, Gone From My Side, The Dying Experience. So there are a lot of small pamphlets and books out there that can help us to set up our own bereavement support programs. Next slide. So at Mayo Clinic, Florida, this is what we have. We have the bereavement package. In there, we have funeral homes and crematories. We have grief resources. We have coping with grief. We put that in a package and we give it to unit managers, and then they give it to people who are bereaved. So that is the only way that chaplains are involved here. Pre-pandemic, the palliative care services here used to send cards as well to families, but during the pandemic, that paused for a little bit. But if a patient from here moves on to Mayo Clinic Hospice, it's different, because they now receive the 13 months of follow-up, 13 months contact from the hospice providers. So it is through cards, emails. They also invite them to children grief events as well, and to other group activities on bereavement. Now, when we look at other things, like before, I talked earlier about pre-death assessment and post-death assessment. So I'm wondering at this time where chaplains come in. Do you do this assessment in your institution before you start providing bereavement support? I know that in another Mayo Clinic institution where I worked, even before the death occurred, they would put a candle in the unit, a picture of a candle burning, and then they would do what we call the bereavement tray that they will bring to families and put it in the room. And they also do the bereavement card with all kinds of bereavement resources inside. And then post bereavement, they start sending the cards and the emails. So who is responsible for all these things in your institution? I know in NICU, A friend of mine shared with me that in the NICU, sometimes nurses spend their own money to buy the memory stones and the heartbeat bears and things like that to do the bereavement process with. So it is good at this point to just think about who provides it and how it is provided in your institutions. I also learned that, so if you are in an acute setting, right, maybe you are in a hospital, you are in an ICU, you die, maybe the healthcare setting doesn't have that process or that rigid standard that says we are going to provide support to your loved one for 13 months. So your family member will not have that kind of support. But if you die in hospice, your family member is going to have that 13 months of follow-up. This is just a food for thought. Is how do we make sure people are having this bereavement support? Let's move on to the next slide, please. Now, what are the benefits of bereavement support? So we heard earlier about the emotional distress, the psychological distress that people go through when they are grieving, and this can build up to depression, it can build up to anxiety. So when we provide this bereavement support, especially when we do structured screening pre or after the death and provide the support, it can help people to reduce the depression, it can reduce anxiety, but it can also improve well-being and coping for the bereaved individuals. Let's move on to the next slide. Next slide, please. So now, what are the barriers? No, not this one, the previous one. The previous slide, please. Yes, barriers to, thank you. Barriers to bereavement support. Andy, could we go to the next one, the barriers? Yes, thank you. So what are the barriers to offering or to providing bereavement support? The first big one is resource limitation, right? Time. We have the problem of time, insufficient time to do this work. So I am a chaplain. I am already doing my full-time chaplaincy work. So is bereavement support integrated? Is that part of my work as a chaplain, or do I have to create extra time to be able to provide bereavement support? So there's also lack of personnel in some institutions. Like in the studies that I saw, they said palliative care specifically provides bereavement support, but they say, oh no, they are short and they are not able to do that. So they are beginning to, in some places in Australia, they are beginning to create these standards that palliative care services will abide by and will use to provide bereavement support. There's also a lack of appropriate services to which bereaved people could be referred in the community. And it could also be character of the bereavement experience. As we said earlier, what are the circumstances surrounding the death? Maybe people feel unsettled. Maybe they are in the situation where they are unable to accept that it is happening, that death has happened. And then there's also inconsistent follow-up of bereaved persons as well. If your institution says we are going to contact this person at 1 month, at 3 months, at 6 months, at 9 months, and then they only do 1 month and 9 months, it doesn't help the caregivers as well. So there's also inappropriate referrals for intervention. Sometimes we rush quickly to pathologize grief or to medicalize it when we are not there yet. So sometimes, oh, this person is depressed, we need to send them to therapy. This person has high anxiety, we need to quickly fix it rather than journeying with the person as well. So those inappropriate referrals can hurt the process. Next slide, please. So in the next slide, I'd just like us to talk about the takeaways. You can put it in the chat. What are you taking away? What are you taking away from this? We know that bereavement support is vital. It's part of the support that we give to bereaved people. So what do we need to include in our bereavement support process? Who provides it in our institution? Do we need to do it differently? And we know that bereavement support can really help people as they grieve and help them to cope, help them to adjust to loss and offer mental health and emotional well-being as well. Next slide. Next slide, please. All right, so this is the last slide, and these are some just questions for reflection for us as chaplains. What resources are needed to set up bereavement support, right? What time do we have? What value do we in this? What are the elements that we need to include in our bereavement support process? And what resources are available either in our healthcare setting where we are at this time or in our communities to provide bereavement support? So with that, I will say thank you for listening, and I will hand over to Sarah, who will be responding. Thank you.
Thank you, Beba. Can everyone hear me okay? Good? Okay. And so we'll definitely have some time after this for questions and discussion. For now, I would just, I'll offer about maybe 10 minutes of thoughts and experiences from my own work. So I've been a chaplain and also bereavement coordinator for most of my career, having worked in hospice and seeing the wonderful models that hospice has for bereavement that most of us are familiar with, the 1 month, 3 months, 6 months, 9, 13 months model. And then also now in my role as a palliative care chaplain here, actually just transitioned out of being the bereavement coordinator here, thankfully, so I can focus more on research. But I have overseen that program for the past 4 years. So for me, I guess what I wanted to lift up is kind of 3 main areas. One is the way that we think about bereavement as chaplains, providing care for patients and families in the hospital. Also kind of the after the death piece, some things that I've learned along the way. And then also just some general resources. So first, I think one thing that's important to remember for us as chaplains is that we bring a particular lens. We're looking at coping, we're looking at distress, we're looking at all these aspects of care. And so I think oftentimes we are supporting and facilitating anticipatory grief. And so it's really important to know our role in that. And I think we can really have a wonderful role in bringing to the forefront some of this anticipatory grief, people's questions, and really to utilize their coping, whether it's spiritual, religious, or other types of coping. And so to not be afraid to bring that into the visit and to really facilitate that end of life reflection, the anticipatory grief, whether it's a death that's expected in a day or in 6 months or a year, or, you know, depending on how serious the illness is. Oh, okay, just lost the slide, so it's fine. And so the other thing, so we bring a particular lens, and I think as chaplains, one thing we can do is we can bring that to our patients and to our team in a way that's unique. And for example, I can think of many times when my palliative care teammates have said, can you go see this patient? Like the wife won't decide about her husband's care, and he's had all these interventions and it's sort of waiting, and he has these treatments that aren't really helping, but she won't maybe be a DNR, she won't move to comfort care, and we can't figure out why. Can you go fix it? Of course, I can't fix it, but what we can do as chaplains, I think, is bring that lens. And so I just got a social history and learned more about her family and her background, and she had had multiple losses. She had had 4 losses in the past 1.5 years, which nobody had thought to ask about. So of course, her grief, which she had barely had time to process, was now impacting her decision to move her husband towards comfort-focused care. Of course she was grieving, and of course she was delaying making that decision. Thankfully, you know, within the next week, several visits, we were able to talk through that, and she was able to come to a place where she appropriately was able to focus more on comfort care. But again, all these aspects of grief and loss, sometimes we can kind of peel those layers back. Also, I see my role as really modeling a way of being with patients to facilitate this grief and also to teach it to my colleagues. So during COVID, well, I guess we're still during COVID, but especially in the early days of COVID when family members were not at the hospital with patients, and I'm sure we probably don't really know how it really has impacted the grief of our entire country and the world. But we did a few intentional things to help with anticipatory grief and potential bereavement. So one thing we did is we did one of those get to know me boards where you write different information about the patient that you get either from the patient, depending on their medical status, or from the family. And so I think this was one intervention that helped the family feel like we were really trying to know their loved one as a person, not just as another COVID patient on event, but someone who has a life, who has a story, who has relationships, that it matters. And so the families, even from afar, were able to do that sharing and that, like, tell us about your favorite song, tell us about your favorite memory, all those pieces that really can positively impact bereavement over time. If the family members feel like their loved one has been getting the best care possible, even in an awfully heartbreaking circumstance. Also, one thing we did then and still do, and to some extent, is a transitional object. So we had these like ceramic hearts that we would put with our patients when they were seriously ill and dying. And then that was something that we could then send or give to the family members after they passed. So the key is it has to be something that's able to be cleaned. So this, these little ceramic hearts were perfect for that. We could clean them and then give them to the family members as something that was physically with their loved one when they were dying. We also do this with children. There's different options you can use, and Child Life often has great examples of that. Okay, so also I just wanted to mention in terms of, triggers, this is the other piece I want to talk about. In terms of our role educating the team, I think it's important to remind the team that the way a patient experiences their care, the way the patient dies, can impact, obviously, the family, impact their bereavement experience. So there were some types of serious illness and end-of-life scenarios that we've taught the team, meaning my medical colleagues, to always reach out to chaplaincy and or social work, because this might be a complex bereavement situation. So some of these triggers are complex family dynamics. If there's just a lot going on with the family around the serious illness, to get us involved sooner, to be aware that there might be a complicated bereavement situation, a history of other losses. So really trying to get to know, has this patient, we had a patient whose wife was just diagnosed with breast cancer just, a week after they were diagnosed with a different cancer. So again, this is a tricky situation that we need to have that bigger lens around grief and bereavement. Palliative sedation. This is actually something I did a little bit of a research dive because I was wondering if a patient who has palliative sedation, how does that impact the grief that their family experiences, right? Does it have a negative impact? Does it have any impact? And as far as I could tell in the research that I did, it doesn't necessarily negatively impact it. But what does impact a family's bereavement response is their distress during the serious illness and the end of life experience. So if a patient is experiencing physical distress, emotional distress, spiritual distress, and the family therefore is experiencing this distress, and it's not addressed by the team through chaplaincy, social work, aggressive comfort measures, that can really negatively impact bereavement. So palliative sedation in and of itself is not a negative for healthy bereavement. But again, just to have that in your mind, like what are things that we can do while the patient is still here with us that can facilitate a healthy bereavement process. So at MGH, we do a handwritten card for our patients who have died under palliative care. So we have about, I don't know how many patients per year, around 70 patients on service under palliative care at any given time. So we still do a handwritten card, then we do the mailings. We also do twice a year, we do a memorial service for the families of loved ones who have died. So it's just within that 6-month period, bumped back a couple months. So actually we have ours tomorrow, which they're now virtual, which is kind of a bummer, but in many ways it actually might be good because it eliminates travel and more people can actually participate in the service. So I think there's pros and cons to both. And one thing that I do is we have a lot of palliative care fellows. So we do a teaching with them on how to do a bereavement call and how to write a bereavement card, which to us may seem like relatively information that we already have or not too hard to do, but a lot of our fellows, our MD and NP fellows, are very uncomfortable making a bereavement call. So we actually partner with them to call the family members of our loved ones, the family members of their loved ones and our patients, just to offer our condolences. But it's nice to do it together with the medical provider because I think they sometimes feel nervous and it's nice to have a buddy social worker or chaplain. Also for the bereavement cards, I actually wrote like a template that I have here, handy things to say. So statements to write in a bereavement card. I was very sorry to hear about so-and-so's death. It was a privilege to have been involved in so-and-so's care. You know, you are a special family. You are a loving support to so-and-so during his or her time here. But again, I just have a script of potential things that our practitioners can write in the card because sometimes they don't know what to write. And I think this has been helpful. And I know it is meaningful to our patients and families to hear from their providers after the death of a loved one. And finally, so I guess I'm just keeping an eye on the time, make sure we have time for questions. I just want to offer, it's really important to know what resources you have in the community. Of course, we refer people to therapy if they reach out to us and it seems like they're really having a hard time, they really have some unresolved stuff that they need to process. We partner with social services here at the hospital. They offer bereavement support groups. At this time, we do not under palliative care just because we don't have enough people to do it, truthfully. But I wanted to highlight that first, there are a lot of grief groups in the community all around the country. There's Grief Share, which is a big kind of faith-based evangelical Christian group that you'll see all over the place. Catholic archdioceses often have free bereavement groups in many, many, many cities all over the place. Again, free for anyone, Catholics or non-Catholics. And also, just to remember that, yes, if you're under hospice, you receive their automatic and often wonderful bereavement support. But hospice bereavement groups are generally offered to anyone in the community, regardless of whether or not your loved one died under that hospice's care. So people don't always know that. And so oftentimes when people reach out to me, if their loved one wasn't on hospice, I refer them to one of our local hospices that have a really robust support group program, both in person and also on Zoom. So it's important to remember that that's a wonderful resource. So thanks. I think we can move now to some time for discussion and questions.
Thank you both very much. That's a fantastic summary of some bereavement stuff. I just wanted to highlight, thank you, Sarah, for bringing up hospice community programs. It's been something I refer people to all the time when meeting a family who may be facing a patient's death. So that's excellent. We don't have a ton of questions that have come in. So I actually have a couple that I've been thinking about. Paul and I were kind of prepping yesterday, and we both kind of hit on a couple of things that we've noticed. One thing in the special interest group that Beba, I really appreciate you bringing up is that there's a variation in context. Bereavement programs in different contexts look very, very different. So in our special interest group, we have folks who are providing bereavement care in long-term care settings, acute care settings, community-based hospitals, large academic institutions, hospices of all shapes, sizes, and configurations. And so seeing how everyone does bereavement care in those contexts is very, very different and quite a fantastic experience. So that's a little plug for Special Interest Group. If you're curious about hearing what other folks are doing, we can get you signed up for that. But the question I have for you guys to maybe consider, so when I was a bereavement coordinator not too long ago, resourcing. So Beba, you mentioned a barrier is resources, people, staff, money, materials. I really love that Mayo, you guys produce your own materials because there's not always a ton of really great materials out there sometimes that we can use that help with some of those more practicality things. So the question I would love to hear you guys chat about is, how do you prove value of a bereavement program in like an acute care setting, like a hospital setting, to boost some of these resourcing? I know the difference in a hospice is there's a CMS requirement, so there is this sort of financial push to build a bereavement program and make it more robust. But for those of us who are not in a hospice setting who would like to see more bereavement care, what are your recommendations? How do you prove value to get some more funding or to get those resources increased? Or what have you done in your context, at least?
Thank you for that, James. That's a very, very important question. And I would think as a chaplain, it will be understanding if we value the care that we give to family members, right? Valuing the care of family members, knowing that they begin to experience this distress when the patient is still alive, when the patient is suffering, and they are witnessing that suffering. So putting value in that and helping our other providers or the institutions leadership know that that is a key moment. That is, we will not only provide care to that patient, but when the patient is suffering, the family member is also suffering. So prepping people for that time and offering support at that time and assessing at that time as well is kind of priming the mind and saying, we are providing this support now because we know when it's going to happen. It's going to have an impact on what is going to happen after death. So if we start saying it is important for us to provide support to caregivers at that time, then make that transition to it is also important that we continue to provide this support even after the patient dies. I think that will be one of the ways that we can put value in this. And I'm beginning to see that bit by bit because of the consciousness that they now have to say, oh, this family is going through this. Let's bring a bereavement tray to help them. Let's do a bereavement cart and have these resources in that bereavement cart to help them. That is making the institution conscious, because I know one of my departments, one of my units here, they applied to have that happen in the unit. So it was piloted in one unit. They saw that it was really helpful. Then they asked for more funding to do it. They started with the ICU, and then they went down to other units to create the bereavement card. But it started small, and the institution knew about it. The manager knew about it. Then they asked for that funding now from leadership. So that was creating that opportunity. Yeah.
I think another thing for us, there's almost, there's never enough resources, and there's always so much we want to do, and it's always a matter of getting buy-in from leadership. And I think so many times, you end up in a place where leadership realizes through some event or some support you provide to staff or in their own life where they think, this bereavement support is really important. I think, barring those kinds of things, it can be helpful to track the amount of requests you get from the community. So one thing is we keep track of, obviously, how many cards we get, how many cards we're writing, how many patients have died, how many family members attend our memorial services that we had. I mean, pre-pandemic, we would pack the chapel for for that memorial service. And then 6 months later, we would pack it again with a completely different group of people. So it was pretty amazing. So just demonstrating that people need what we are providing and that the need continues. Also, for me, when I was in the role of bereavement coordinator until quite recently, I would track anytime someone reached out to me from the community looking for bereavement resources. And so sometimes it was the family member of a patient, but a lot of times it was just like a random person who would say, my family member died and I don't know what to do. So I just tried to keep track of how many times people reached out, if it was email or phone call, how much time I spent supporting them. And then also if they were looking for groups or if they were looking for referrals to therapy, but just so you get a picture of really what we're dealing with. So then you can say, this is how much time I've been spending doing this. And wouldn't it be great if we had more time to do even more? But yeah, I mean, I think it's baby steps, and we can't do everything, and we have to partner with our community resources too.
Excellent. Thanks so much. That's really, really helpful.
That's right, Sarah. That feedback is really important, right? Like when we do the yearly memorial services, the feedback that we get from families when they go back home, they write letters to really acknowledge that how they felt affirmed and valued, and that if they remembered them, to call them back a year later to do that bereavement service. So when we collect this feedback and give it back to leadership, it really helps. It puts value in what we're doing. Yeah.
Well, we have a few kind of concrete questions, so I want to get to that after this one if we have time. But this is actually an important question. I think it's come from the chat. And this has been raised in the special interest group as well. So the question is, there was some research a while back about the effects of sending condolence cards on families whose loved ones died in an ICU. I think that was the research primarily, and that the potential of re-traumatization from these cards. So the question is, how do you balance the tension of sending a card that's appropriate, but also the potential of causing harm when we don't know on the other side of that card how it's going to be received? What are some thoughts or reflections on that sort of dilemma?
Want me to go? Okay. I would say one of the ways could be the relationship that we had with the caregivers when they were in the ICU or in the or wherever in the hospital. Knowing the people, knowing the caregivers, and we know we've said it here that grief can come in waves, and there are certain things that really trigger. It could be that moment, that the memorial dates when the person died, or the holidays, and when we send these cards, it could also be a trigger. So knowing the people before in a hospital, and I don't know if there is a right or wrong way that we can really find the balance. It's a tricky place, because you don't know what is going to happen at the receiving end. But the intent from this other end is we are doing good, but it could actually be a trigger, as the person asking the question is mentioning. But I would say maybe the relationship can help you know that people, and maybe can envision how intense their bereavement is, or how intense their grief is, how they would receive it. But there's just no way, because if 1 month has passed, you don't know where that person is, how they are feeling at that time. So to me, I would say it's hard to know.
Yeah, I mean, I think it's an interesting question, because, you know, the death has happened. So to mail a card, you know, within a couple weeks, to me, I guess, I suppose if it's very, you know, traumatizing, or it brings up stuff, you know, they can just throw it in the trash. But no, I mean, I don't mean that. But like, I think, you know, for mailings and things like that, one thing we do is any letter we send, we always have a clear way to reach out to us and tell us that you don't want to receive any more mailings. So email and a phone call. So I guess just to make it easy for people to opt out if they want, and to opt in more to other resources if they need it. So always including like a person's contact info, name, email, so they feel like it's not this like nameless flurry of constant letters about death. Yeah, I mean, I think, and it's interesting too, the idea, like, is it better to get bereavement support from a person that you did know during your time in the hospital, or to have like a completely fresh face reach out to you and provide bereavement support? Like, I know in hospices, oftentimes you do have a designated bereavement person who calls them, you know, meets the family for the first time after the death. In some places that can be wonderful. For some situations, it can be wonderful. In other situations, it might be like, who is this random person calling me? So I think to think about the quality of the experience, about the illness trajectory, about the end of life process. And I know for me and for many of our patients, I think to have at least one follow-up phone call or letter or something from the provider can be really welcomed by the family. But again, just to give them the option of opting out when and if they need that.
That's fantastic. Yeah, it's a really great point, Sarah. So just to kind of wrap us up here a little bit, we're doing really well on time, so thank you, everyone. There's a couple of concrete questions that's come in about some of the things you've mentioned in your presentation about the grief tree, or the bereavement tree, excuse me, and the cart. Would you mind just describing a little about what that is, just for a couple of minutes? That topic in the special interest group particularly comes up as what are some concrete things we can do in different settings? So I think this has raised a lot of curiosity.
Yeah, thank you for that. Yes, the bereavement tray is mostly food that, just like food that people can start snacking on as they wait, because there's a lot of waiting at that time when people are waiting maybe for withdrawal, people are waiting for different things, just sitting there. So we bring the bereavement tray, and then we accompany that as well. So we don't just say, here is the tray, you start eating. But sometimes a chaplain accompanies that tray to sit there and provide the support, any support that the family needs. But it's mostly food, snacks. Then the bereavement cart it has all kinds of bereavement support resources. It has memory stones, and sometimes we write on ones that have like brother, sister, aunt, uncle, hope, faith, peace, and we ask people to pick a rock. So we take out the rock and we say pick a rock. People will easily say, okay, this was my mom. They pick a mom rock, or an aunt, or whatever relationship they have with that person, or they pick the way they are feeling. They feel peaceful. Is it I have faith at this moment? They put it in their pocket, or they hold it in their hand. And I've realized that that really brought comfort to people. We also have blankets, like prayer shawls in it as well. We have pamphlets on how to cope with grief. We have all kinds of little things like candles. Then the hand, as we call this, the memory pillows, and the memory film papers, where people could like do the hand the name is escaping me. What but just more memories. Yeah, the handprints, the film papers that we used to do the handprints, and note cards for people to write whatever they're thinking, whatever they're feeling. We have color books and color pencils as well. And if it's in the NICU, or different kinds of resources are present as well for people to just draw things if there are children involved as well. So that's the makeup, some of the things that goes into that bereavement card. But we found that they've been very helpful to keep people going as they wait. Yeah.
Yeah. So essentially, things to keep families engaged in the vigiling time, right? We call in some settings.
Yes. And people are really happy to do those activities. They take my loved one's handprints. I will keep this. It's like creating a legacy. So we also have those legacy resources, little things that people can do. Yeah.
But I think I love those examples. And I think part of it too is just having grief and bereavement be part of the conversation, be part of the way that we're thinking as a team about the care that we're providing, right? To not have this kind of narrow framework, but again, to think about how the holistic care we provide as chaplains, social workers, medical providers really impacts that journey of the family for a long time. And small things done very well and done with love and with care really can make such a positive impact on a family. And so, to just remember to bring it into the conversation, right? And to think through that as a team whenever we're talking about patients and families, but, and other people, their history of loss, again, their history of their experiences and their spiritual resources that they can use to draw on that we can really bring that lens, and it can positively impact the bereavement process.
Yeah.
Hi, Paul.
Knowing their resources prior, yeah, right? Knowing their resources, knowing how the cope can really impact and help the way we care for them after. So that's important.
I'm going to step in only because we're getting near the top of the hour. So to Beba, to James, to Sarah, to Andy, huge thanks. So much goes into this effort behind the scenes. I so appreciate all that you've done to contribute to this. To those who have joined us, thank you as well. There were a lot of questions that we didn't get to, but what is clear are the advanced practices that many of you have within your own context. So I apologize that we didn't get to some of those. I learned a lot just even through reading some of those. So please keep after this. About 450 of you registered for this. So it was a clear indicator that we've tapped into a need that perhaps we'll revisit again, but I so appreciate this. I'm just going to click through a couple of slides here at the end. Andy, would you go to the next slide, please? We have some upcoming pieces. I forgot to say Happy Spiritual Care Week for those who are in that celebrating kind of mood. We have another webinar with Transforming Chaplaincy that we'd love to have you join for us. A screening is something that Dr. George Fachet has been after, I think, since Fred Flintstone roamed the earth. So, please come in. He's going to be a part of that. But so screening, check it out on Friday. Next slide, please, Andy. Betwixt and between, another really cool, fun webinar that's being planned. Jeannie Wirpsa for the Chaplaincy Functions Network is pulling that one together from a great article with Dr. Klitzman. So please consider joining us for that on November 9th. Next slide, please. And then on the 2nd, we are headed close to that winter holiday season. So best practices and telesupervision, especially if you're an ACP educator, this one might be right up your alley. Next slide, please. If you have a little time and you want to join us and put a little extra elbow grease into some work, please join us for Research Literacy 101. Our next session, as I mentioned, begins in January, and Research Literacy 102. And I'm proud to mention that Beba is one of the instructors for that course as well. So please consider joining us for those. Those are the QR codes. Check out our website. Again, thanks for being with us. Have a great afternoon, everybody.
Thank you.
Thanks, everybody.
Thank you, Angie.